Okay. Good afternoon, John Sullivan here. I'm going to give a quick talk on version. We will do a 15-minute panel and then a 45-minute coffee break just to keep everyone on the same page in terms of expectations. I need to poll the audience before we do this. I need to know, we're going to talk about one of the more esoteric aspects of obstetric practice and certainly of obstetric anesthetic practice. How many of you do versions at your institution that you're aware of? Okay, so it looks like 90+%. How many of you participate in neuraxial analgesia to anesthesia to facilitate them? 50 to 60%, I'd say. How many of you, is it primarily a systemic opioid analgesic methodology, or maybe you don't know? How many do no analgesia that you think of? I think that's maybe a third of the room. Nitrous oxide, I'm hearing. How many, you may not be aware of this, do other techniques like acupuncture or moxibustion? Any out there that? Couple. Okay, just wanted to get a sense of things. Disclosures, and it's certainly interesting to hear some comments in the last panel about off-label use of drugs. You know, I suspect a great deal of what you do in your daily practice is off-label by FDA definitions. Maybe you don't know it, but in this realm, all intrathecal opioids that we use are off-label. So is terbutaline as part of the tocolytic process. So I'm going to go a little bit over the context of how this fits into public health and cesarean deliveries. I want to talk a little bit about what factors increase success and specifically what you do to increase success, can increase the success of this, and then talk a little bit about technical details. I think the context to frame this in perhaps is that we spent a great deal of time in the 1990s and 2000s, early 2000s, defending the practice of neuraxial labor analgesia, specifically with regard to does this practice and our work, that's really the core of our work in obstetrics, lead to increased cesarean delivery. I think we successfully refuted that you probably don't have to have much discussion around this these days. It still comes up, but there was a great deal of work that went into refuting that argument, and certainly some of the randomized controlled trials we did at Northwestern at the time certainly went a long way to do that. This is the only thing an anesthetic practitioner can do to directly contribute to the cesarean delivery public health problem in the United States. My attempt in the next 30 minutes is to convince you that doing neuraxial anesthesia for external cephalic version to convert breech presentation to vertex is the only thing you can do personally to reduce the cesarean delivery rate, and I will provide some evidence behind that. In general, we don't personally find ourselves making decisions about whether a patient should have a cesarean delivery or not. In fact, as an obstetric outcome, it's one that's heavily biased by the judgment of obstetricians. It is clearly a balance between what is best for the mother and what's best for the child, not just in terms of morbidity, but some rare risks of mortality. In general, the practice of attempting to turn a baby from breech to vertex and try to avoid a cesarean delivery is accepting probably some mild neonatal risk to reduce ultimate maternal risk in the realm of increased placental invasion disorders, bleeding, etc. But it's hard to model these things, and I think you just need to be aware of it. The cesarean delivery public health problem, if you want to frame it in that context, I think as many of you know, has increased almost 50% the rate over the last decade and a half. The important thing is, despite what has been the most substantial investment of resources in obstetric practice, so if you want to go at cost effectiveness in the world of obstetrics, if you want to talk about bundled payments or value-based care, you can actually focus all of your efforts on just one thing, and that is cesarean delivery or not. I sat at part of my new role as I sit down with groups of payers and discuss pay for performance. all they want to talk about, and justifiably so, because that's where all the cost is. It's on cesarean delivery. So there's a couple things here to think about. Quality outcomes, patient outcomes, and cost are important, but we've invested an enormous amount in this uptick in cesarean delivery. We've gotten nothing for it. Gotten anything in terms of reduction in cerebral palsy? No. If anything, we've gotten more morbidity and more maternal mortality. So this is an important public health problem. This is what this curve has looked like. The 50% increase, I think you can see a trajectory, part of the late 1990s. The curve has flattened out since about 2008 or so on, and we're starting to make a little bit of progress on it. The point that I have an arrow at in this cesarean delivery rate over several decades, and isn't it interesting to look back at the CDC data from the 70s? Not only were the rates pretty low, but nobody was even looking but every few years. Isn't that kind of interesting? The big uptick in the late 90s had to do with a decrease in enthusiasm for trials of labor after cesarean delivery. But the one that's relevant for this lecture is that the enthusiasm to do breech vaginal deliveries fell way off after this trial, which I'm about to show you on the next slide. Just to give you some background, if you're breech, you have a couple of options. You can deliver someone vaginally, and that was historically something that was generally done. As you know, probably very few of you are seeing this today, despite some conflicting evidence, actually. You can just go straight to cesarean delivery, or you can attempt to do a version with this trans-abdominal manipulation of the child. Well, this is the HANA trial that essentially contributed to part of that uptick in cesarean delivery rates in the late 90s. A large randomized controlled trials. If you have breech presentation, and think about it yourself, women in the room, if you were breech, how ambivalent are you to participate in a clinical trial where you're randomized to cesarean delivery or breech vaginal? I mean, that's something hard to get your head around these days, isn't it? Well, this is a Canadian trial. They've been very successful in conducting some of these large breech trials over many centers. But this was the primary outcome in this trial that I showed you. It was clear that delivering babies breech vaginal delivery seemed like it was not the best thing for the baby. Interestingly, a follow-up study of this several years later, looking at how these kids did as their brains developed over several years, there was no difference. However, the practice changed substantially, and it looks like we don't appear to be reversing to go back to breech vaginal delivery, but this is the paper that did it. This represents a small single-digit percentage of our total cesarean deliveries, total number of pregnancies, because of the compounding effect of repeat cesarean deliveries. It's a little bit larger percentage of our total cesareans. Obstetricians' skill at turning a baby widely varies. It probably isn't fair just to call it skill. It probably also has to do with their own risk profiles. A lot of people perceive this as a little bit of a risky endeavor to try to do this, thinking about cord accidents and creating abruptions. My sense is that the 30 to 85% success rate in turns has a lot to do with that, not just skill. I'm going to walk you through a couple things that help predict outcome, but really what I want to focus in is on your practice. These are the general priorities one thinks about when you're doing a version. Obviously the mother and baby's safety, the goal of turning this kid and getting a vaginal delivery and avoiding cesarean, but then the secondary outcomes of pain relief, satisfaction, and cost. What is this? I described for you the theoretical risk of doing this is that you could potentially shear the placenta off the uterus wall and create an iatrogenic placental abruption. You can also have cord accidents. If you can imagine that you could easily compromise a cord in maneuvering a baby this much. But these are the numbers in terms of published incidents. They're generally small, but I think more importantly, and these are data from a trial that we have presented, and it is a pre-publication, not in press yet, but this was essentially 11 years of retrospective data. This is essentially case cohort data. These are all the women at Northwestern University who were offered ECV and either had it done or were not offered it or avoided it. And for the most part, it was that they refused it. We pretty much offered it to just about everyone. You can see the numbers. It's about 4,000 women. Most importantly, though, if you look at all of these measures of important neonatal outcomes, that whether you try this or not, it looks like your neonatal outcomes are about the same. I think I described a little bit about obstetrician skill and risk as part of someone's professional personality, but I think there's also some other dynamics about this. It's a painful procedure. Some reasons of a obstetrician might abort this procedure has to do with how uncomfortable a patient is, and there's some dynamics that present in the published trials that had to do with selection bias, which I'm not going to spend too much time on. Just so you know, there are obstetric things that predict success. If this kid's head has not descended into the pelvis substantially, you're going to have a greater chance of turning it. Paris women are easier to turn, presumably because of a slightly thinner uterine wall. And obesity probably also impacts on things to some degree. Undoubtedly, the evidence is overwhelmingly in support of the use of tocolysis. In fact, there's been numerous randomized trials comparing different tocolytics. Beta agonist is probably what most of you use, but just so you know, I think nitroglycerin probably is fine despite 3 flawed trials publishing inferiority and reporting inferiority to a beta agonist. It probably had to do with the duration of the drug. This is a slide of pain scores of women who've had versions. In black bars are those that were able to turn. The lighter colored bars are those that had failed versions. If you just look at it in its total, what you know is this is a fairly painful procedure. In fact, this is what inspired us to start doing neuraxial anesthetic techniques in the early 90s because it was painful. We knew how to eliminate that pain. We had some theoretical concern that we don't want to block their sensation of their abdomen to the degree or block motor strength of their abdominal muscles such that it would allow an OB to push so hard that maybe you could increase that risk of iatrogenic placental abruption. So here are your options. As you described, there's many in the room who their practice is that they don't participate in this. Their anesthetic practice is not a part of it. I talked to you a little bit about some of the Eastern medicine influenced practices. I'll show you just a brief data on that. Systemic opioid is seeming to decrease in terms of its use, and I'm not surprised in this sophisticated obstetric anesthesia audience. There was very little presence on the survey at the beginning. But of neuraxial techniques, we know there's a range of things. I'm always intrigued when you talk to an obstetrician or really any other individual outside of obstetric anesthesia that they kind of pool all of our techniques into one thing. And we know that we have several different modes that we can deliver a neuraxial anesthetic, and we have different concentrations ranging from analgesic type blocks to anesthetic. And there's a little bit of technical detail in there that is often missed outside of our specialty. Here's the data on this, just so you know it. 8 randomized controlled trials out there on moxibustion. If you don't know what this is the burning of herbs at several points on a person's body that honestly I don't understand it that much. It doesn't make that much sense to me. I certainly do believe in acupuncture and some of its benefits, but just so you know, the 8 randomized controlled trials on moxibustion alone showed no difference in flipping kids, but there is a single trial out there that's intrigued a lot of people that moxibustion and acupuncture has led to reduction in breech presentation and reduced cesarean deliveries. Whether that can be reproduced, it's not clear, but many people, including my own obstetrician, my own obstetric anesthesiologist colleagues have tried this with success. No downside, is there? The systemic opioid, to give you a background, our practice had been for years to give systemic fentanyl. But remifentanil probably is the drug of choice if you're going to match drug to procedure and pain experience duration. I think this looks probably to you like looks a little bit like nitrous oxide, looks a little bit like systemic opioid for labor. You know, a 2 VRS drop in pain score, a little bit of uptick in satisfaction. Curiously, in this Chinese trial, not an insignificant bump in their success rate and ultimate reduction. And ultimately, it didn't really pan out in cesarean, but I think you're talking about small numbers of patients, so I wouldn't put too much emphasis on that. The point I primarily want to make in this 30-minute talk is that neuraxial anesthetic techniques are powerful in that not only can they increase the success rates of these procedures, but we now have the statistical power to say that they actually reduce cesarean delivery rates. Again, I'm going to repeat, it's the only thing you can do in your obstetric anesthetic practice that can directly reduce cesarean deliveries. Again, the whole background, not talking about us increasing cesarean deliveries, this is us making a difference in a positive way. I'm going to go through some of the technical aspects of this, some of the details for you. First of all, pain and satisfaction. These are data from our first trial that we did almost 50, I don't know how much, it was early 2000s. In the solid box, you see combined spinal epidural analgesia. This was essentially the equivalent of what we, almost exactly what we still do for labor analgesia at Northwestern now, compared to the black box, the hashed box plots that are systemic fentanyl, 50 mics of IV fentanyl. Not a true random controlled trial because it was systemic opioid compared to a neuraxial technique. Substantial benefits in pain and satisfaction. If you look at, there have now been 9 randomized controlled trials that kind of looked like what we had done. A small number of patients, several dozen patients randomized to either some neuraxial anesthetic technique or control, and showed increased ECV success, decreased breach at term, or increased, I should say, vertex, and decreased cesarean delivery rate. There are the relative risks and the confidence intervals, and it really took until this last trial where there was enough strength to demonstrate crossing of parity on the meta-analysis, and there's the meta-analysis that shows the diamond clearly favoring neuraxial anesthesia relative to cesarean delivery rate. I'm sorry, that was actually procedural success, not cesarean delivery rate. Several different techniques you can use. This is the low-dose technique, the one that we did as part of our first trial. This kind of looks like labor analgesia. The theory was that we wanted to get patients comfortable. You saw the pain and satisfaction scores from that first trial. We didn't want to provide so much numbness that we were perhaps increasing that risk of, theoretical risk of increased iatrogenic placental abruption. But other people were doing high-dose spinals, and Carolyn Weininger, who has published the highest success rates in this in Jerusalem, was doing a high-dose technique. Not quite the doses you'd be using in a cesarean delivery, perhaps. Some people do cesarean deliveries with these doses, just so you know. And other techniques, some people did, what were essentially surgical anesthetic dosed epidurals with those doses of 2% lidocaine. When we published our first trial, there was a bimodal distribution of outcomes based on this high and low dosing. The two of us that did the analgesic dosing, you see on the bottom, with a diamond that's crossing parity, no difference in procedural success and ultimately cesarean delivery. Those that did the high dose clearly had an increased success rate. That inspired our follow-on trial that we conducted. We randomized now a large group of patients, 240 women who had breech presentation at term, into 4 groups of 4 different doses of intrathecal bupivacaine with fentanyl. Those are the groups. The lowest one was the one we did in our first trials. The higher ones up towards Carolyn Weininger's trial, and even one that superseded that. We presumed that we were going to see some dose response effect, probably somewhere between 2.5 and 7.5 milligrams of having the optimal success rate. We were surprised by this outcome. The blue data points here are the success of the version, and you can see almost identical across all those dose groups. And in red is the cesarean delivery outcomes. So this was a surprising finding in a multi-year, large randomized controlled trial that really seemed to conflict to some degree with previous randomized controlled trials. I'll back up here one second. It's probably, if you look at no analgesia, systemic opioid to low dose, there is clearly a relationship between your anesthetic intervention and success rates, but probably that inflection point is between the lowest dose here, 2.5 milligrams of bupivacaine, and what would be no analgesia or systemic opioid. So the dose response study was designed all skewed where you would have observed this inflection point. I think it's also important to note these things, that unlike your laboring patients, these patients are a little bit more vulnerable to hypotension, particularly if you're getting into larger dose intrathecal bupivacaine injections. And it brings up the point, if you are going to go there, you may start to think of this in the same context that you think of spinal for cesarean delivery with prophylactic vasopressor. I think it's rare actually that people do that, and we particularly had more problem, I think, than other individuals who had done investigations in this. I think we just we must be just lazier about left uterine displacement or something. The group at Stanford did some work on whether it's cost effective. As I described to you, cesarean delivery is the most expensive thing that we do in obstetric practice, but so are we. Our interventions are expensive. Even bringing a patient in to attempt to do an outpatient procedure is not inexpensive. There is pretty substantial evidence to suggest that doing the procedure itself is cost effective if your success rates are over 32%, and our intervention, our expensive intervention, our participation is justified in terms of cost effectiveness if we can increase that success rate by at least 11%, and that's what the published evidence shows. So where do we stand on this? Carolyn Weininger, who I alluded to earlier, did a large administrative database study of practice in the United States. This was, the national inpatient sample represents about 20% of the U.S. obstetric population. Essentially identified over 1 million women with breech presentation. Look at the percentage of women that got aversion. I showed you our center, which was very pro-intervention, had a 30% acceptance rate. So the broad U.S. population has only a 10% participation rate. So there's a lot of missed opportunity in reducing cesarean delivery there. And what else was seen in this? Well, just exactly what you would expect to see, that those that did participate in this and have a successful version obviously had a reduced cesarean delivery rate from an almost certainty of 95% down to 20%. Again, there are still women you flip, they'll go into labor and they'll be sectioned for an arrest of dilation or something else. But you did see reduction in all of these other quality measures, endometritis, sepsis, and length of stay in those that participated in this. And that's not surprising at all. Nor is it surprising that you saw a mild uptick in chorioamnionitis in those that flipped. Almost certainly if you compare women when you compare women who have elective cesarean delivery versus those that labor, you will see that. But overall, that's something that is a small price to pay to reduce cesarean delivery. So in conclusion, employing neuraxial techniques, participating in versions in itself is an important part of addressing the public health problem of versions. Your participation in this with a neuraxial technique, at least statistically, appears to impact this, and it's the only thing you do that impacts this. That it's probably a cost-effective practice and that it's still probably substantially underutilized in the United States. Thank you.